Hello and welcome to a Pediatric Dermatology Research Alliance educational webinar. This program, titled Real-World Clinical Experiences Managing Epidermolysis Bullosa with Birch Triterpenes, is hosted in partnership with Chiesi. I am Jen Dawson, Pedra's Director of Educational Programs, and I have no conflicts of interest or disclosures relevant to this program. I am pleased to introduce our speakers, Dr. Emily Gorell, Assistant Professor of Dermatology at the University of Colorado, and Dr. Joyce Teng, Professor of Dermatology at Stanford University. I will now turn it over to them to state their disclosures.
Thank you so much, Jen, for that introduction. I'm Dr. Emily Gorell, and these are my disclosures. So I've been a consultant for industry, including serving on several advisory boards, and I'm also an investigator on several clinical trials.
Thank you so much, Dr. Gorell. Now I'd like to give it to Dr. Teng to summarize her disclosures.
Thank you very much, Jen, for having me today. I'm Joyce Teng, Professor of Dermatology and Director of Pediatric Dermatology at Stanford. Just like Dr. Gorell, I collaborate with the industry and have served as investigator for multiple EB clinical trials and consultant for several industry as well as patient support group as medical advisors.
Thank you both so much. Now I would like to turn it over to Dr. Gorell to begin her presentation.
Okay, so I am going to introduce EB, Epidermolysis Bullosa. So EB is a group of rare blistering genetic skin conditions, including EB simplex, junctional EB, dystrophic EB, and Kindler syndrome. The types of EB are classified based on the gene and the protein that are affected, as well as where that protein is in the skin. So in the table on the left, you see the whole giant list of all of the genes and proteins affected. And then on the right, you have this schematic of the skin that I've edited to kind of show where the different types of EB are. So this here is EB simplex. This is due to variants in several different proteins, the most common of which are keratin 5 and keratin 14. And it affects the basal keratinocytes. And then deeper into the skin at the junction between the epidermis and the dermis, we find proteins that are implicated in junctional EB, which can have a severe form as well as an intermediate form. And then below the basement membrane zone, in the sublamina densa, is collagen 7, which makes up these anchoring fibrils. And mutations in collagen 7 causes dystrophic EB, which can be either a dominant form or a recessive form. So in terms of the epidemiology of EB, this is a question I get asked a lot, and our estimates vary widely. So back in the 1980s, 1990s, there was a national EB registry, and specifically for recessive dystrophic EB, the incidence and prevalence were estimated to be about 1 per million. However, since that time, we've been recognizing more and more of these milder forms of EB. And then with genetic testing, we've also been finding people who were misdiagnosed as, maybe they thought that they had, dominant dystrophic EB and they actually have mild recessive dystrophic, or maybe thought they had simplex, they actually have dominant dystrophic. So I think that, those estimates are really changing. And you can see in the table on the right, just how widely these estimates can vary. In general, the RDEB incidence is estimated to be, it was estimated to be 0.2 to 6.7 per live birth. And then now with some genetic modeling, the RDEB incidence may even be as high as 95 per million. And then with this method, actually the group at Stanford estimated that there were about 3,850 patients in the U.S. with RDEB. And the estimates for JEB also vary. Incidence is about 9 to 14 per million births, and the prevalence is 1 to 2 per million, which is accounting for, unfortunately, that there's quite a high mortality in some of the more severe forms of junctional EB. So we're going to be focusing on dystrophic and junctional EB, And the main thing that we think of in terms of cutaneous symptoms is going to be wounds. And you can see some of the photos on the right. And there's a couple different classifications of wounds. So there's recurrent wounds, which are wounds that will open and close, tend to be in the same areas, areas that really have friction and trauma over time. And then eventually those wounds develop more into chronic wounds and wounds that just don't heal. And unfortunately, those chronic wounds in certain EB subtypes can predispose to a skin cancer, as you can see in this photo on the bottom. This was actually a patient of mine who gave permission to use this photo, but he developed this, squamous cell carcinoma, despite the fact that he was on immunotherapy. So that is one of the other very feared symptoms of EB. Other cutaneous symptoms that we see are granulation tissue, which is a predominant feature in junctional EB. I'll have some more photos in an upcoming slide. Chronic infections, we're always trying to keep a handle on infection, as well as pain and itch. They lose nails, and then also loss of hair. These are some more photos of recessive dystrophic EB. You can see this chronic wound on the upper back, which is an area of pretty frequent friction just from sitting and laying. In this picture down here, you can see the pseudosyndactyly, or mitten, previously called mitten deformity of the foot. And then you can see some, chronic wounding, blistering here as well as some hyperkeratosis. You can also see these oral erosions in this baby's mouth. And in fact, you can even see on the tongue that lack of the lingual papillae, which is a clue to the diagnosis of RDEB in a newborn. And these are some photos of junctional EB. So here's that granulation tissue that I was talking about, or it can be thicker. And in junctional EB, it really does like to be around the mouth. This is a patient with the more severe subtype, and you can see the extensive wounding in the neonatal period. On the left, these are patients with the intermediate subtype, and you can see the loss of nails, as well as this pretty characteristic alopecia and wounding. So this is a very busy slide discussing the extracutaneous manifestations of dystrophic and junctional EB. The main takeaway from this slide is that EB affects almost every organ system and does require a giant team of multidisciplinary specialists to really care for it, to care for the patient, including the primary care doctor, including the eye doctor for corneal abrasions, the dentist. Junctional patients can have airway involvement, so you need ENT and pulmonology. Sometimes you need a cardiologist. We very heavily rely on our GI colleagues because some of our patients can have esophageal strictures and they need dilatations. They can have reflux, constipation. Hand in hand with GI is nutrition, because patients often have malabsorption or just difficulty getting enough nutrition in between the oral erosions, the esophageal strictures, and then all their calories are going towards wound healing. And often we'll need to have a gastrostomy tube. I showed some photos of the pseudosyndactyly, so we work with our hand surgeons. We need our hematologists for treating anemia, as well as, very importantly, and not to be overlooked, is mental health with our colleagues in, psychology, psychiatry, and social work. But really, it does take a team approach to really care for these complex patients. And on that topic, there are quite a few clinical practice guidelines now, which is exciting and is very helpful for people caring for EB. The most recent of these guidelines was guidelines for esophageal strictures, which just came out in the British Journal of Dermatology in 2025. We have guidelines for inpatient management. The wound care guidelines, I believe, are probably being updated soon. Importantly, there's guidelines for emergency management. The anemia and palliative guidelines are new as well. And there's also guidelines for OT, PT, and I think that this guideline actually on sexuality is very important, because that's not really a topic that we are very good about talking about with our EB patients. And I think that it's something that we need to be talking about. So I think that guideline is really important, and kind of reminds us that these are topics important to patients as well. But these guidelines all do exist and are eventually being updated, and so they're very helpful in caring for these patients. And then now I will turn it over to Dr. Teng.
Well, thank you for the introduction at that nice background discussion, Dr. Gorell. And I'm going to spend the next few minutes to talk about TEB management and current therapeutic landscape. So we'll review briefly about the goals of the therapy, current therapies that are approved and available to our dystrophic EB patients as well as the junctional EB patients. And I will discuss briefly about my personal treatment considerations when I approach a patient and these therapies. We will also spend a few minutes to go over a few real-world cases of junctional EB patients that I've taken care of. As Dr. Gorell mentioned, that management of EB starts at birth. It really takes a village. Here are several of the core services in our multidisciplinary EB clinic that participating in a patient care other than dermatology. And in addition, as patients grow up aging, and we know that with multi-system manifestations, we're going to require other services such as cardiology, pulmonology, renal, just a few to be mentioned. And if we focus on just the wound care part of the EB care, considerations for how to take care of a wound, including, age-specific requirement, characteristic of the wound and severity of the wound itself that we know oftentimes associated with the genotype and pathogenesis of the EB itself. Total body surface area involvement obviously is a consideration. But in addition, size of these chronic wounds and the risk of infection and site of instrumentation, as I just mentioned, for example, G-tube, and the require a specific consideration as well. So how much damages a patient have had already at their site. And so all of this factor into our shared decision-making and how we manage and treat these wounds. So this is the first topical gene therapy for dystrophic EB from Crystal Bio using a HSV viral vector to deliver collagen 7 gene into keratinocytes or skin cells. And this was approved in May 2023 first, which is followed by another different therapy from Chiesi using a topical formulation of Birch Triterpenes in sunflower seed oil to help improve wound healing, reduce skin inflammation, reduce pain and itch. Fortunately, this year in May, we have our third therapy for EB has been approved using autologous keratinocytes that transfected with viral vector that carry a normal copy of the collagen 7 gene. These genetically modified keratinocytes are propagated to grow into skin grafts that were surgically placed on the wound for dystrophic EB patients. So if we just to focus a minute on the Birch Triterpene, which is the only therapy so far approved for junctional EB patient as well as a dystrophic EB patient. And in clinical trial, there was very mild side effects associated with this therapy, mild skin irritation, pruritus, a little bit of a discomfort at the application site. And here are a few of the examples that are published in the phase 3 clinical trial study using Birch Triterpene. As you can see, the smaller wound, for instance, between 10 to 20 square centimeters, and they healed much faster than the bigger wound on the right side of the panel, 30 to 50 square centimeter wound that takes a few weeks longer to heal. But overall, you can see the improvement. There are over 100 wounds included in this study. In comparison to the control, there are 44% increase the probability of target wound closure at day 45, comparing the group using the Birch Triterpene versus the control group. And the pediatric group specifically, for those that are under 17 years old, there are a total of over 70 wounds. There's a 70% increase in the probability of a target wound closure at day 45. So the patients did a benefit from the treatment that led to the approval. So, of course, all of these newer therapy are somewhat expensive, and it requires insurance approval for patients to access to these therapy. Put the cost on the side. If we think about just, which therapy should I choose, and what are some of the considerations? It goes back to the mechanisms and how these therapy are delivered. So, delivery of the treatment itself, whether it's in clinic, at home, or required surgical intervention, it's oftentimes important part of the decision making we have to factor in, but also the size of the wound and the disease burden itself, how big of an area the patient and parents and family are interested in addressing with these therapy. And what are the quality of the wound? Are these acute or chronic, or, places that cause significant pain and itch and impair patients' quality of life? What other factors such as durability of the treatment that we need to take into consideration. As you can tell, that this is a complex issue, and the mechanism of the treatment of these treatments are somewhat different, and perhaps that they can complement each other, and perhaps the combinational therapy can benefit our patients even more. And aside from gene therapy and wound-targeted therapy just mentioned, additional treatments are still in development because there are still a lot of unmet medical needs, as you can tell. So there are protein therapy and cell therapy. There are also drugs to be repurposed to target a certain type of genetic variants, such as gentamicin, also in clinical trial, as many of you may have noticed in the clinicaltrial.gov website. To other drugs that can perhaps help to address the itch and pain, skin inflammation, such as biologics that were initially developed for other inflammatory skin diseases, such as atopic dermatitis and psoriasis. So there are a lot more to come, and it's really due to years of amazing research. And this is we're at a very exciting time in terms of EB therapy. So I'm going to share quickly about the two of the patients that I have taken care of using Birch Triterpene. The first case is a 2-year-old with junctional EB due to LAMC2 mutation. The baby has had multiple complications due to infection and poor pain control. You can see before and after photos on this slide before we started the Birch Triterpene treatment on the left side, and as well as a 6-month post-treatment. Patient did have a lot of pruritus or itch associated with this particular area that require additional therapy, such as Dupixent to address the itch and self-injury behavior. Nonetheless, an amazing response in a very challenging area that was occluded. The second case is an 8-year-old, also has a junctional EB due to LAMB3 mutation. The patient has more generalized skin damage and involvement that had lots of pain, difficult sitting, and many episodes of infection in the past. As you can also tell, the patient has had some notable improvement after we start topical treatment to address the wound healing and itch, skin inflammation on the right-hand side. You can see some of the previously involved area. It has improved from significant inflammation to light erythema and some of the wound closure noted in a weight-dependent sitting area, but also on other frictional areas such as the elbow, is one example. So now I'm going to have before I have Dr. Gorell share her experience. And my takeaway from taking care of these patients that were treated was Birch Triterpene is that wound bed preparation is terribly important, and we need to make sure there's no bacterial colonization or infection before we start with the therapy. So cleansing and special dressing, topical antibiotics, it can be helpful. And also it's really important, as mentioned earlier, if we start therapy on a small wound, it usually closes rather fast and compared to bigger and more chronic wound. So start treatment early, combination therapy using other treatment options to address itch or even oversweating, known as hyperhidrosis, are important. Then follow up with your physician to address when therapy is not working the way it's supposed to, is really important as well. So now I hand it over for Dr. Gorell to share her experience.
Yeah. So thank you so much, Dr. Teng, for sharing your cases. And before, I get into some of my cases, I really wanted to just hone in on this slide and echo how important each of these are. I think that making sure that we have good control over infection is very important before using any of these additional therapies. And good old-fashioned techniques like, diluted bleach and diluted vinegar are excellent mainstays. But I really wanted to mention how important it is to combine therapies, because no one of these therapies is going to be, the one thing that's going to make their EB better. We have to use every tool at our disposal, and including, treating exactly what Dr. Teng was saying, including the itch, because if you're scratching, then you're causing more wounds. In our EB simplex patients, that increased sweating, which makes more wounds, and then combining these FDA-approved therapies together to really get the best outcomes for our patients. So that being said, I will share a few of my cases. So I do take care of more, adolescents and adults. And this is one of my patients. He's a 25-year-old male with RDEB. And he is he's very, very diligent about his wound care, and you can see on the left this image of his wounds that were very hard to treat prior to birch bark triterpenes, and then you can see after. I mean, it's a little blurry, but you can see there's no wounds there. So he has integrated the birch bark triterpenes into his regimen of daily showers. He cleanses all his wounds with a hypochlorous acid, and then he treats all of his wounds with the birch triterpenes. Some patients prefer to apply the triterpene to the bandage. He prefers to apply them directly to the wound and then covers with a bandage. And he's got about 25% of his body involved, and he uses about one tube for his whole body. He also, in discussing, the importance of using multiple modalities, he also is using BVAC weekly to a larger chronic wound on his back, which is healing. He has had several squamous cell carcinomas, unfortunately. However, he did a little experiment, and he used the birch triterpenes to the Mohs wound. So after they had cut out the skin cancer, they knew they had clean margins. He had, a pretty sizable wound on his foot. And he applied the birch triterpenes to that wound. And, he, in his own mind, was comparing how fast it healed to how fast his prior Mohs sites had healed. And this one did heal faster. I have a quote from him. He says, I am seeing a lot of areas heal faster, and that extra time healed translates to stronger skin. My armpits especially were one of the worst spots, and they were in a constant cycle of blister heal, maybe 2 days healthy before blistering again. Now they have been closed for weeks at a time, and when they do blister, they are smaller local areas that don't balloon over the entire section of the body. And then since he gave that quote, I saw him back in clinic, and he wanted me to mention that he's actually started to grow hair in his armpits, and he never had before because he always had these wounds and too much scarring. So he was very excited that he was having some armpit hair. And this is another photo of his. This is his dorsal foot. And so you can see on the left prior to applying the birch triterpenes, and then after. He also added that the triterpenes are super easy to apply. It doesn't add extra time to the dressing change, and it washes off easily. This is another patient. She's a 10-year-old female who has recessive dystrophic EB. She has been applying the birch triterpenes about 3 to 4 times a week. She is also on dupilumab as well. The mother feels that with the birch triterpenes, the wounds heal better. And she feels that this project is easy to use on the skin folds and on the neck. And the neck has been a particularly problematic area for her. She's treating most of the wounds. They're also applying BVAC weekly, and they kind of, just depends on which wound is bothersome until that wound heals, where they're applying the BVAC. To look at some of her before and after photos, you can see here the photo of the buttock and the upper thigh, where she had these smaller recurrent wounds that open and close. And you can see after the birch bark triterpene application that this area is healed, as well as on the leg. You can see these wounds prior to triterpene application, and then you can see that they're healed afterwards. And this is another area on the back where there were some wounds prior to birch triterpene application. And then you can see afterwards that those have healed, although, of course, she did, start to develop additional blisters at untreated sites. So in summary, birch triterpene topical gel is indicated for treatment of wounds associated with dystrophic and junctional epidermolysis bullosa in patients that are 6 months of age and older. The birch triterpenes will provide patients with EB an additional treatment option to manage their wounds, part of that whole toolbox we were talking about. An appropriate preparation of the wound bed and continued care with an experienced healthcare professional is really important to address the symptoms and the overall disease burden in these patients, and is really a key to success in their outcomes.
Well, thank you both so much for those wonderful presentations. If you will allow me, I would love to transition to a mini Q&A. So my first question that rose to the top for me was really patient adherence. How are patients managing this at home?
All right. Thank you for that wonderful question. And my experience taking care of EB patients for so many years is that when something works, and people will stick to it. And therefore, we need to absolutely set the right expectation, how long it might take to work, and use the therapy correctly to make sure it works better. For example, that Dr. Gorell has shared some of her experience about using this and patient feedback, but also make sure that they use a sufficient quantity and use it on the adequate surface. And so preparation is really important. If the patients don't use it on the correct site in the correct way, then of course the therapy is going to be less efficacious. And so really applying it correctly is important.
What does it feel like when it's going on the skin? And maybe what's it feel like right after? What are you learning from patients about the feeling on the skin?
You want to apply to the wound bed, but notice the difference between the edges and the wound bed itself, because the moisture that already in the wound bed, right, before you don't have that feeling of the film. But if you're supposed to in order to get a better treatment results, and you are recommended to go a little beyond, maybe like 1 to 2 centimeter beyond. Okay. Notice there will be a little film also, like a sealed it in medication in place, and don't be alarmed, don't worry, and that's adequate, even if it can be washed off very easily.
Both called out the importance of the wound care prior to application and making sure that it's decolonized, making sure it is not infected in any way. So how are patients managing that portion at home so they're prepared for the Birch Triterpenes application?
So that's very patient dependent. So every patient does their wound care regimen a little bit differently. I've never seen two patients that do their wound care the same, even in the same family. So I think the importance of bathing is really important. Bath time is very hard. It's very painful. It's traumatic. It's anxiety provoking. But we have methods to deal with that and to help to allow bath time to happen. I think that, the importance of bathing and cleansing can't be overstated. And that's really the tried and true methods to try to get rid of and to decrease that bacterial burden. So bathing, showering as frequently as possible, and dressing changes. If you can't do every day, at least every other day. But those are some ways to decrease infection. You can also, use, diluted bleach, as well as you can use diluted vinegar. If you have, concerns for Pseudomonas, just don't use the diluted bleach with the diluted vinegar. But, you can alternate those. And also using some, antimicrobial dressings like silver dressings are other tactics that you can use to decrease that bacterial burden. But, it is an uphill battle that, families struggle with, and, we as healthcare providers struggle with as well, because we're trying to not have to use our antibiotics, but sometimes we need to.
Yeah, I agree. Antibiotic resistance is a real problem in the EB population, and it is important to think about all different means and ways and to address and to prep the wound bed correctly, so we do not or we're trying to minimize the antibiotic resistance as much as possible. However, for us as a healthcare provider, and gave some general structural to their wound care regimen, and so they understand, why they should prep their wound in a certain way and what they need to do. The general principle is still very helpful.
We talk about how there's so many different specialties involved in the care of somebody with EB. So when their skin is being managed successfully with the Birch Triterpenes? How is that affecting other specialties and other elements of their care?
That is a tough question. I don't think that we know yet. I don't think that there's necessarily data about, kind of the downstream implications. Yeah, the goal is to improve, their nutrition, their anemia, because if we're able to heal the wounds on the skin, then some of those calories that, that they're getting, those precious calories don't necessarily have to go towards wound healing, and they can go towards growth. So that is the ultimate hope. But we just don't have that data yet. Hopefully we'll be getting that data in the future.
Yeah, completely agree. I think many of the manifestations that we discussed in this webinar early on, and the damages and systemic and manifestation all started with the skin. And so that if we can stop the instigator for this multi-system disease and can improve wound healing and better protect the skin, I think that it will minimize the long-term complication of the disease. But this is why, Chiesi and other company that have developed these treatments for EB community have has started to implement plans to actually have long-term follow-ups and systemically to evaluate the efficacy of these treatments.
Yeah, wonderful. Well, you just answered the question that my colleague Catherine asked. She's thinking with her Pedra hat as our research manager for our focus study groups, and she just asked, what's next? Where are we going from here? Which is a really important question, and you both did a great job answering that. And until we can get that real world data in, we'll keep on keeping on. But I think from perhaps a Pedra investigator perspective, how do you, taking this information that we've just discussed here into our genetics focus study group, how might investigators be thinking about how they can contribute to the next step of research in this area?
This is clearly a very important, but yet more complex question to address. And it requires our better understanding in order to manage the disease better. It requires a better understanding about the natural history and the genotype-phenotype correlation of different, subtypes of EB that we know, even for junctional EB and recessive dystrophic EB patients, depending their genetic variant and their manifestations and clinical characteristics are different. And so collaboration between different investigators and different groups are so important for us. We have discovered a lot over the past decade, but there's so much more work and so much more research can be done for us to understand that aspect of the disease better in order for us to choose the right medication and really deliver a personalized treatment regimen for these patients.
Yeah, and I think I 100% agree with Dr. Teng that we need more data on genotype, phenotype, and how to personalize our treatments. In that same vein, I think that also as investigators, we can do something that the individual companies may not be able to do, where we can discuss more of our cases of patients that are on combination therapy and investigate efficacy and safety of these sort of multimodal therapy plans. And we can only do that with collaboration across the country and across the world, frankly. We all have to, work together because each of us has, a few cases here and there, and the powers are in numbers. And bringing us all together is something that, that Pedra really helps us out with.
Do you have any final thoughts that you want to share, particularly as we prepare to release this webinar and Q&A during EB Awareness Week? Perhaps a call to action for our patient partners as we move the field forward.
Thank you very much for that last question, Jen. We are really in a very exciting time with all the new advancements and that we all have experienced in over the last few years. And so I'm excited by new therapy, and I'm excited by these upcoming therapies. But really, in order for us as a clinician to be able to take care of our EB patients, we need to collaborate, and we need the EB community to continue being our partner and to participate in clinical research and involved, especially in these long-term follow-up projects, and for us to collect the data, collect the evidence, and so we can serve the EB community better.
Absolutely. Dr. Gorell, your final thoughts?
I was just going to, echo what Dr. Teng said, that we do this, this research, and we take care of our patients because, it's so important for us to be able to help you. But also, you can also help us and help each other by, participating in these clinical trials. Because really it is a community. We have a community of researchers, a community of clinicians, a community of families, community of advocates, that we're all in it. We're all in it together.
I couldn't agree more, and I can't think of a better way to close our discussion. Thank you both so much for marvelous presentations. I know that our viewers and listeners will appreciate it tremendously. And I also want to thank Chiesi for supporting this webinar. It has been tremendously valuable. I know our membership, as well as other practicing pediatric dermatologists and dermatologists, will also find it valuable. So thank you so much, Dr. Gorell and Dr. Teng, for joining us today.
Thank you so much for having us, Jen, and appreciate all the participants and people who are listening. It's a privilege of taking care of EB patients for me.
Yes, thank you so much for the opportunity to discuss, our cases and discuss EB and share the stage with Dr. Teng. And the more, awareness that we have for these treatments, then the better care that we can have for our patients with EB. So thank you very much.
Once again, thank you so much to Chiesi. This webinar is hosted by Pedra and sponsored by Chiesi. Pedra will evaluate content for suitability for its audience, but it's not responsible for the creation of content, selection of speakers, or delivery of presentations. Please note, this presentation is not a substitute for medical advice, diagnosis, or treatment. Any decisions related to medical care should be made in consultation with a qualified healthcare provider. Looking for more EB-specific education? Be sure to follow us on social media at Pedra Research, where we will be sharing updates and new programming. Coming in December, we will be releasing another program in partnership with Chiesi titled Epidermolysis Bullosa, Wound Care Management and Real-World Application Considerations Using Birch Triterpenes, featuring special guest, nurse practitioner Nicole Halliburton from Cincinnati Children's Hospital. You won't want to miss it. For more educational resources, please visit Pedra's website at www.pedraresearch.org. And for more information about current EB clinical trials, please visit clinicaltrials.gov. Thank you so much for watching.